All right, everyone. Well, we'll go ahead and get started to be respectful of your time. I'm Todd. I'm the Outreach Education Coordinator down at Children's, as well as one of the simulation coordinators. I'm a nurse, a paramedic. I've been at Children's. It'll be 10 years. I did 9 years on the transport team before coming to this role. So I'm new to this role, been in it about since September, but have some clinical experience to back up my knowledge, hopefully. Some of my knowledge. Larissa is with us as well. She's a PICU nurse by trade. She's been in a PICU for 20 years and has been in with the simulation team for a couple years now. And we both kind of made the transition. We both have young kids about the same age, and just hard with our families working those hours and then the mental angst of working those jobs. So we both changed. We enjoy our roles, but this is who we are. In your packets, you'll find the PowerPoint if you want to follow along, take any notes as we're going. Sheila is our presenter after this. She'll be presenting on burns, pediatric burns. She's one of our burn program coordinators. She'll bring her presentation with her. And then on the left side are our evaluations. So we do need an evaluation from everyone to get CEs for the course. So we have to make sure we get your evaluation. They are CE'd separate, so just make sure by the end of the day you filled out both evaluations and got 2 certificates. Also in your packet are disclosures you'll find. I've heard that when the Board of Nursing is auditing nurses, they're asking for these objectives or now outcomes. We've changed it to an outcome. So I've suggested people, when you get your certificate, just staple those to it so you maintain those together. So that's the outcome. And then our objectives kind of delineated out. So I'll try to make this as interactive as I can because I know that people don't like to interact typically, but it's better for better learning capacity. So any guesses on how many children in the United States are hospitalized each year with injuries? Just a guess. And it's probably on your paper, so don't look ahead. I should have deleted them.
Next script they'll be deleted.
How many? Anybody think? Any guesses?
4 million.
4 million. High. 175,000 kids each year. And this is hospitalized, so there's obviously more kids are injured, but these are kids that are actually hospitalized, admitted to the hospital for that. Any guesses on what percentage of teenagers wear their seatbelts?
60%.
Well, that's a good question. I think it's 54% was a survey done by the Highway Safety Organization, so 54%.
And that's a survey that the teenagers answer,
Yeah,
right?
So it's probably lower than that. How many kids suffer from concussions every year? 1 million. 1 million. This doesn't necessarily mean hospitalization either. This could just be, and obviously 30,000, or so we can see 30,000 of theirs actually have some sort of deficit or some sort of result from those. Do you think having a kid be seen in a pediatric trauma center versus an adult trauma center improves outcomes? That's pretty obviously yes. So by 25% is what we see there. How many children are killed each year in serious injuries in the United States? Any guesses? These are big numbers. So about 10,000. So still a lot. We see that trauma being a cause of death is still a huge leading thing for kids between the ages of 1 to 18. I mean, obviously 2,000 compared to 10,000 as our cancer being our second cause is a huge number. So we're seeing tons of these kids. So we say trauma is a disease. It is predictable. We see it. We know what causes it. And it's also preventable. So we do identify trauma as a disease. In our area, we have our Central Ohio Trauma System, which is down in Columbus. I'm not sure if your guys' region is actually part of COTS. You might have your own trauma organization up here. And then we have the American College of Surgeons, which verify all of our trauma centers throughout the United States. Probably know this. Trauma centers, any kid less than 16 years old, so 15 and below needs to be admitted to or transferred to a pediatric trauma center. And then older than 16 should be seen at an adult trauma center. Trauma centers out through Ohio. You guys are here. You're a level 2 adult trauma facility. We're down here at Children's, level 1. Cincinnati is a level 1, and Rainbow Babies is a level 1 adult and pediatric trauma center. Those are your trauma centers in the area. Toledo, I think, I thought they were a level 2 pediatric, but maybe not. They're not on my list. So most of your guys' severe pediatric traumas are coming down to our facility. That's kind of the closest to your region. But we have our trauma facilities extended throughout Ohio. There are some level 1 trauma centers in Ohio, but not very many. When we look at trauma, we want to look at the mechanism of injury, so what caused the injury. These are just some different sorts of ways injuries can be caused. I think you guys are all familiar with that. And obviously there are more than just those. So we'll just kind of start and go with, so when we divide trauma out, we typically divide it out between blunt force trauma, penetrating trauma. Those are the two indicators, so we'll just go through those. So we know blunt force trauma is caused by an external force. We can sometimes see it on the outside, but we don't actually know what's underlying or what's really going underneath. So it's not obvious or easy to diagnose. So we're using CAT scans, and these kids are getting a lot more radiation to try to figure out what's going on than a penetrating trauma. And more common in pediatrics, we see more blunt force trauma than we do penetrating trauma. It does happen, but it's not seen as often. Blunt force trauma, this is a classic seatbelt sign. This is a seatbelt across the child's abdomen. That indicates there could be underlying damage or underlying injury there. So then we have penetrating trauma. An object or something pierces through the skin. These are kids that were all seen at Children's. This kid was seen at Children's. This is a broomstick handle that is impaled his neck. Can anybody tell what that is? Yep, it's a music stand. Yep, and that's a kid's scalp. This is from a lawnmower. I don't know this personally, but I've heard that this was a lawnmower, like the blade came loose and flew and hit the kid. So this would be kind of a combination of injuries. Obviously something penetrated, but we can see there's a lot of crushing injury there as well. This is the kid with the broomstick handle through his neck. We can see he was taken to the OR, obviously removed. He actually did not damage any of the underlying structures, so his carotids, nothing like that were injured in this. It was pretty relatively easy to remove. Then we can look at thermal injuries. Thermal injuries can be caustic in nature, whether it's a chemical type burn, whether it's heat, electricity, radiation. This kiddo, this one here was some sort of chemical. I don't know which one, but this is a chemical burn. This kid's in the OR getting ready to either be debrided or who knows what they're doing at this point. This is initial stabilization. And then this was a toddler-aged child that stuck his hand up on the stove, like one of the glass flat-top stoves, and burn his hand. And we'll obviously burn injuries are going to be covered more in depth this afternoon, so you'll be able to get more questions answered about those. And then we have asphyxial trauma. Children's, we don't actually identify these as trauma as much anymore. They're just asphyxial injuries. So drownings, hangings, those things aren't actually level 1 traumas or level 2 traumas. They're just an asphyxial trauma that we manage in our ED. This is a across-the-board advanced trauma life supports, a program that most of your physicians probably have gone to since you're a trauma facility. Some of your nurses may even have gone to this. So this is kind of what I've built the presentation on, is kind of their process in advanced trauma life support and how we evaluate patients that are involved in traumatic injuries. So it's a systematic approach, and it goes through these levels of these steps. We start with our primary assessment, resuscitation, secondary assessment, and then definitive care, and we'll go through these. In advanced trauma life support, we go through our A, B, C's, and A through E, really, but we include F at Children's. Does anybody know what A stands for? Airway. We also, a lot of times, will clue in alertness, so we can evaluate their level of alertness just on that little quick assessment. We're not doing a GCS or anything like that here. We're just doing a quick, are they alert or not alert? B is breathing, right? C? D? Disability. Yep. E? Expose, and we include environment here as well. Children are obviously more likely to become hypothermic in a trauma room. They're being undressed, unclothed, and potential to be cold. So we add environment in here so to clue us in to keep them warm and stuff like that. We'll go through that more in detail. And then at Children's, we involve in family-centered care. We include the family in everything that we possibly can, so we include that in our trauma assessment to make sure that they're at the bedside. So during our primary assessment, these are what we're looking at with our airway. So is their airway patent, basically, is what we're looking at. Is it patent or not patent? And we're including C-spine immobilization. So that may be manual traction, or most of your patients that come in from EMS are going to be on a longboard with a cervical collar. But we're maintaining that C-spine stabilization during that whole process. So is it obstructed or patent? And then when we look at their level of alertness, we go with the AVPU score. Is everybody familiar with that? So they're alert. If we talk to them and they wake up, it's verbal. If we have to sternal rub them, it's painful. And then U is unresponsive. So they don't respond to anything. And then we go on to assessment of breathing. The main things we're looking at on breathing, is it adequate? This is not a full assessment of our respiratory status. It's, are they breathing effectively at this point? So we look at a quick, is their effort good, or are they really distressed? How fast are they breathing? Is it relatively the appropriate speed? We may not be counting them, but are they really tachypnic, or are they really apneic, or, I can never say it, bradyapneic, which is but breathing slow. Is it equal? And then we do a quick auscultation of lung sounds during this assessment portion of our assessment. Then we can also identify pneumothoraxes. During this primary assessment, like I said, it's building on it. So if we identify something during the assessment, we correct it at that point. Any emergent life-threatening changes, we correct at that point. So we would correct some of these if they were severe enough during the assessment. Closed pneumothorax, most likely to be blunt force trauma or barotrauma of some sort. This would be what we call a sucking chest wound, so it's an open pneumothorax, air's coming in. And then this is a tension, so we can see it's under tension. The trachea is deviated and everything else is deviated to the one side. There's a mediastinal shift. So then when we look at circulation a little bit differently in the pediatric population than we would the adult. So we're going to assess their perfusion by pulses. Do they have distal pulses or only central pulses? If their distal pulses are absent, they're probably hypovolemic and need some sort of treatment. Capillary refill is a good indicator in kids. We don't use that as much in adults, but we do in kids. So we're checking their nail beds or anywhere on their skin to look at their capillary refill. We can also compare that central versus peripheral. If they're more clamped down peripherally, their capillary refill is going to be more delayed in their fingers than it is maybe on their chest. Color. Are they pink? Are they mottled? Are they cold? You know, all of that can go into here. There's temperature. And then mental status is a good indicator of circulation. A child, just as an adult, if they're not perfusing their brain, their mental status is going to be altered. So if they're obtunded or unresponsive, maybe it's because they're not perfusing their brain adequately. During this stage, we're also identifying life-threatening bleeding and controlling it. And this is where I talk about in kids. Hypotension is very rare in kids, and there's a slide we'll cover later on in the presentation. An adult, you may see hypotensive just from a little bit of blood loss. A kid is not going to be hypotensive until the very end, and then they're going to be in impending arrest. So we need to make sure we identify that early and correct it early. So these are all different injuries. Here, I have trouble seeing it. Larissa tells me that there's a handprint here from like an abdominal injury. This was a chainsaw. Somebody was working in the tree, had the chainsaw above their head, lost control and hit their head with the chainsaw. This was a lawnmower injury as well. So these are the reason I have them here is these are life-threatening bleeding, life-threatening hemorrhage that we need to control immediately. Obviously, they're somewhat under control at this point, but the scalps bleed like crazy. So then when we go to D, this is a little bit more of a thorough exam than, so we're looking at disability. This is where we would include looking at our pupils. Are they equal? Are they responsive? All of those sorts. We have our Glasgow Coma Scale, which I'm guessing all of you are familiar with, but sometimes we struggle with scoring that. Everybody scores it a little bit different. We're going to watch a video on it. The Glasgow Coma Scale actually was 40 years last year, right? 40? Yeah, I think it was 40 years anniversary. So it's been around for a long time. It's widely used in adult and pediatric populations. We know the scores between 3 to 15. Each one, you can give a general score, but that doesn't necessarily indicate anything. It just gives you, I mean, it does, but we also need to know, kind of divide them out. Which one are we not doing properly? And then we evaluate centrally versus peripheral neurovascular exam. So can they squeeze? Can they follow commands with their fingers, move all their extremities as more of an in-depth exam?
Clinical assessment of consciousness is often crucial in the care of a patient with an acute brain injury. This film will provide you with a practical guide to using the coma scale that we developed in Glasgow to ensure reliable assessment and clear communication about the patient. We'll show you how to make a series of standard observations of 3 aspects of the patient's responsiveness: eye-opening, verbal, and motor responses to stimulation. Steps in each component can be rated according to defined criteria to show the degree of impairment present. We'll show you how to record and communicate your findings, how these can be used, and provide you with a downloadable summary.
When assessing a patient, there are 4 steps: check, observe, stimulate, and rate. The preliminary check is used to identify any factors that might interfere with your assessment. It is important to identify local factors, such as a hearing impairment, that could cause a lack of capacity to respond. Following these preliminary checks, we observe the patient, noting any spontaneous behaviours in any of the 3 components of the scale: eyes, verbal, or motor. The patient is rated in each component by matching findings with the corresponding criterion. There are 4 criteria for eyes, 5 for verbal, and 6 for motor score. For each component, the top criterion is a normal response, whilst the lowest criterion is no response. If the patient's eyes open spontaneously, spontaneous is recorded. Remember, there may be local factors, such as swelling, that prevent eye opening. If spontaneous opening is not demonstrated, a verbal stimulus is used by introducing yourself clearly and requesting eye opening, if necessary by shouting. If the patient opens their eyes, to sound is recorded. If the patient does not open their eyes when you speak to them, a physical peripheral stimulus is then applied. Stimulation starts at a low level by pressing on the nail tip and is applied with increasing intensity for up to 10 seconds until the patient demonstrates a response or until maximum stimulus has been applied. If the patient opens their eyes, record to pressure. If they do not open their eyes, record as none. If there are local factors, such as swelling, interfering with eye opening, record eyes not testable. To assess the verbal response, ask the patient to tell you their name, where they are, and what month it is. If they answer correctly, record orientated. If during conversation the patient is able to speak in phrases or sentences, but is unable to give the correct answers to these questions about orientation, record confused. If they do not talk sensibly, but utter single words, record words. If the patient moans and groans with no recognizable words, record sounds. If the patient makes no sounds at all, then record none. Remember, speechlessness may result from factors other than depressed consciousness. For example, the presence of an endotracheal tube. In these cases, record verbal not testable. To assess the motor component of the coma scale, first ask the patient to perform a 2-step action by asking them to grasp and release your fingers with their hand, or opening their mouth and sticking out their tongue. If the patient does this, record obeys commands. If the person can't move their arms, for example because of a spinal injury, you should ask them to open their mouth and stick out their tongue. In a patient who does not obey commands, a peripheral stimulus alone is inadequate to assess the motor component of the coma scale, and an additional central stimulus is needed. This is first applied by the trapezius pinch. To perform this, place your hand over the patient's shoulder and press your fingers into the muscle above the shoulder blade. Apply pressure with increasing intensity for up to 10 seconds until you are sure that the response you observe is the patient's best response. The second location for central stimulus is the supraorbital notch. Apply this stimulus if there has been no localizing response to the trapezius pinch. This stimulus is applied by placing a hand on the forehead with a thumb over the upper rim of the orbit. Feel for the notch in the supraorbital margin. Apply pressure with increasing intensity for up to 10 seconds until you observe the patient's best response. The patient should not be rated as having an absence of response until the maximum stimulus has been applied. This stimulus should not be used on patients with facial injuries adjacent to the supraorbital notch. If the patient moves their hand above their clavicle or collarbone in an attempt to move the stimulus away, record localizing. If their upper limb does not reach above the clavicle but does flex, then they are either normally or abnormally flexing. In clinical practice, the assessment of these non-localizing responses is based on a combination of both peripheral and central stimulus. In normal flexion, the elbow bends and the arm moves rapidly away from the body and from the stimulus. In abnormal flexion, the elbow bends slowly and the arm comes across the body. If in doubt, record normal flexion. If the patient extends their elbows rather than flexing them, record extension. A patient who makes no response is recorded as none. If they are paralysed by other factors, such as paralysis by drugs, record motor not testable. If different responses are exhibited between limbs, on right and left sides, record the better side response as the best index of overall responsiveness. The response of the worst side may reflect focal brain damage or local injury. So, to recap, check for factors that might interfere with your assessment. Observe the patient for spontaneous eye opening, speech and movement. If necessary, then stimulate the patient, first verbally and then physically. Findings should be documented clearly on a coma scale chart. The observations can then be clearly communicated and the trend rapidly appreciated so that any improvement or deterioration in a patient's condition can be seen. Patient ratings can be documented numerically as a shorthand aid to quickly record findings. When describing the patient, always use the full criteria alongside the numbers to ensure that the assessment is accurately understood. The shorthand numbers can also be added together to give a total coma score. This provides an overview summary of the severity of the patient's condition, but this score does not communicate the more informative, detailed description of each response, which should always be used in addition to the score in clinical care of an individual patient. This approach to assessment has been drawn together into a structured summary that you can download from the website glasgowcomascale.org. Here you can also find more information about the use of the coma scale assessment.
All right, so then we move on to the E, which is our environment and our exposure. Your patients that are involved in trauma should be fully undressed. Typically we cut their clothes off because they're most likely immobilized. This allows for a thorough examination and assessment. So we can find any injuries that maybe we would have missed in our general overall appearance. You know, there's a cut to the back of their right thigh that we would have missed. Following the exam, the patient then should be covered using a bear hugger or something like that. IV fluid should be warm to maintain a pediatric patient's temperature and keeping the environment warm. Especially on those pediatric patients, remember your patient's body temperature is more important than the comfort of the healthcare providers. So we have coagulopathies as we get cold and all of that, so we want to prevent all that and make sure we keep our patients warm during this process. We're already potentially bleeding, we don't want to make it worse. And then, like I said, I'll talk about family. Just remember those parents are potentially patients as well. They've gone through a trauma. Either maybe they're patients in your facility or they're patients because they're emotionally distraught because their child's been traumatically injured. Family involvement can lead to decreased level of distress and increased patient satisfaction, which is important. It allows for communication. Parents know their child the best, so get that information from them, gather the information from their parents. If the parent looks at you and says, something's not right, you need to listen to the parent and follow up and see what's going on there. It's good to have a dedicated healthcare provider with a parent. Oftentimes we use our social or our pastoral care people. They have some medical knowledge so they can guide them, but it's great to have a nurse or somebody with medical experience that can explain something a little bit better than someone who doesn't, like I can't think of a good pastoral care. Most of them have hospital experience, but family presence does not create a delay in patient care or their safety, so it's important to keep them there. It should be offered even during invasive procedures as long as your hospital policy allows it. We allow families in our trauma resuscitations and our code resuscitations. Family can be present if they choose to. With the caveat, if they're distraught enough to interfere with what you're doing, then you have to get them out of the room. That can occur. But in general, we see it works well having them there. They can see that everything has been done, and then if you have a poor outcome, it gives them a chance to say goodbye to their patient or to their child or whoever it is, their grandchild. And it starts that grieving process and a better acceptance. So now we'll move on to the interventions. So these interventions could occur during your assessment. Obviously, we talked about our C-spine stabilization. When we talked about patent or unpatent, so if the airway is patent, then we can put on 100% non-rebreather. All of our traumatic patients should be on a 100% non-rebreather. If it's obstructed, we need to figure out why. So is there just vomit? Is there blood or something like that just needs suctioned? Is the patient's mental status too low that they just can't maintain their airway and need help opening it and keeping it patent? Is there an obstruction? Teeth. Obviously, I talked about blood or vomit, but there could be teeth. Anything else from a traumatic injury. Glass, I suppose, anything like that could be causing an actual foreign body obstruction. When we open the airway, we use a jaw thrust rather than the head tilt chin lift since we're maintaining C-spine. So nasopharyngeal or oropharyngeal airways are to consider if we can't maintain their airway. OPs we want to use on our patients that are obtunded, unresponsive. If you go to put an OP in and the patient starts to gag, stop. It's an easy assessment indicator. They don't need an OP airway if they're gagging. NP airways are great. We can put those in semi-conscious or even conscious patients. We just want to be cautious if they have any sort of facial trauma or we're concerned that they may have a basilar skull fracture. And then if we still can't maintain their airway, then we need to consider intubation. We'll talk about intubation later on as well. Also within this, we can alleviate those pneumothorax, tension pneumothoraxes. This is not, I got an x-ray and they have a pneumothorax, but they're not under tension. This is emergent life-threatening tension pneumothorax that we need to alleviate at this point. If they have an open chest wound or what we call a sucking chest wound, we can cover that, make sure no air is getting in. If we intubate, CO2, pulse ox can be attached at this point as well to identify. What part of the pediatric airway, now we'll talk about pediatric airway in general, what part of the airway do you think causes the most airway resistance out of all this? Chirp, chirp, chirp. So your nose and mouth accounts for about 40 to 50% of your of your airway resistance in the pediatric patient, which is much more significant than the adult patient. We can talk about a pediatric, this is an adult airway. It's cone-shaped. That's typically, now we're using more cuff tubes, but this is why adults always got cuff tubes, and this is why kids did not get cuff tubes. The smallest part of the airway is below the vocal cords, so we would put in an uncuffed tube, and it would seal off typically as well. We're using cuff tubes more frequently in pediatrics, but that would be the difference. This also allows for pooling of secretions and anything like that down there. Babies, smaller kids have large occipits, creating greater risk for airway obstruction or not maintaining their own airway. If this patient was a little bit unresponsive or a little bit lethargic, is going to be more likely to have an obstructed airway than an adult or an older patient that doesn't have that large occiput. And we can see the towel roll simply just to keep it open. No neck or short neck, as we can see in this guy, no neck. Their tongues are proportionally larger in their mouth as well, so their airways just are a little bit more difficult and tedious to maintain than the adult patient. So when we look at intubating, we have to, it's not, there's no right or wrong answer. It's a gray area, and there's lots of things we have to look at. First, we have reasons why, non-patient factors and patient factors. So is the patient, for you guys, most of your transport to children are going to be along. So if there's risk of the airway deteriorating en route, it's better to maintain the airway, start that definitive airway here than en route. It's going to be more difficult to intubate a patient in a helicopter or an ambulance than at your facility, also with a lot less resources. You guys have anesthesia probably in-house 24/7, I would guess, or at least available. And then we have patient factors. So they can't, if they're just not maintaining it, and what we've done, obviously it's not, a patient that's not maintaining their airway can't be bagged, well they can, but it's not very effective to bag them the whole way and maintain an oral airway. They probably need to be intubated for a transfer at that point. And that kind of goes into the non-patient factors again. Severe head injury, if they have a severe head injury and we want to control their ventilation more, we can consider intubation if they're not maintaining their airway. I talked about that already. Ventilatory failure, so are they not breathing? Is their CO2 through the roof? And those kind of things. Are they in severe shock? And then if we consider the GCS less than 8, that doesn't mean every kid that has a GCS less than 8 gets intubated. We on transport did GCSs on everybody, and DKAs would be notorious for, I would transport DKAs with a GCS of 5 and we wouldn't intubate them. So that's not always a good indicator. It's a good rule of thumb. If it's less than 8, consider intubation. When we talk about pediatric equipment we're using, you guys have Broslow carts in your ED, so your Broslow is a great resource not just for medications. On the back side, it'll actually give you equipment sizes, so it's a great resource for you to have. I would say probably the best indicator for you guys are all ED, right? Yeah. So you don't have patients wait typically, so this is going to be your best indicator. And in an emergent situation, these low volume patients, it's better to use a cognitive aid. In your packets, I have one of our cognitive aids as well. You can use that. We'll give you some guidance for normal values of a kid and all of that. But here's another formula if you want to remember a formula. That's the one I always remember. 16 plus the age in years divided by 4. There are more. If you're using a cuff tube, decrease it. And then I always learned the depth was 3. So the correct tube size, if this kid should get a 4, then the depth should be 12. Doesn't mean that's what you're putting in, but by math, if that's what you're getting, that should be your approximate depth. Our protocol at Children's, this hasn't really gone out to community hospitals or referral hospitals as much. We still see them using etomidate a lot and stuff like that. Children's, we don't like etomidate. It's actually shown that just a single dose of etomidate can cause adrenal insufficiency long term in the patient's process at Children's. It doesn't mean we won't use it. We just want to make sure we get some steroids on board to make sure we get that adrenal suppression fixed. So typically what we do in our traumatic patients is atropine for those less than 1 year old. One year old. If we're concerned that there's going to be a vagal response, we would use it as well. You guys will know that atropine used to always have a minimum dose. 0.1 milligrams was across the board was the minimum dose. That's no longer recommended. So we go down as low as we need to go. Just use the 0.02 milligrams per kilo. If we think there's a head injury, we use lidocaine to blunt some of that increased injury by putting a metal object in the kid's mouth. Ketamine's kind of relatively contraindicated in head traumas. We do use it at Children's. There's some research data that would suggest that ketamine increases ICP. But again, like I said, we do use it at Children's even in those head trauma patients. And then paralytics, it's going to be either ROC or VEC most likely are the common used. We use ROC. I used ROC more on transport because it was pre-mixed. I didn't have to mix anything. It was quicker. It has a little bit more rapid onset, but relatively the same duration as vecuronium. Succinylcholine is pretty uncommonly used anymore. The only time we used succinylcholine was we actually did use it on neonates, which was relatively contraindicated as well, but we did. We didn't use it in the pediatric population. When we get to circulation, it's good to know how much blood volume a kid has. So a typical kid has 80 mLs per kilo of blood volume, circulating blood volume. And then we can look here at our vital sign changes. So I talked about blood pressure. Heart rate's normal, normal BP, hypotension to 25 to 30% of blood loss. And that may be mild hypotension that you don't notice. It can be up to 40 and 50% where you see severe hypotension. So your first indicator is going to be your heart rate. A kid's whose heart rate, if the kid's calm and his heart rate is elevated, think hypovolemia. Now if he's agitated or has a fever, that obviously increases your risk of, increases your heart rate as well. So you have to look at all those. But we can see. And same thing with the skin. Skin relatively normal. Okay, now we're getting a little bit of change, but maybe not a lot. And then we're having severeness as we get farther. Urine output, this here, but not commonly really does not give you a good indicator in the ED. It's not like I can do a Foley and say, oh, his urine output's low. I mean, that's monitored over hours of time. Our CNS does give us a good indicator of hypovolemia. So circulation interventions, like I said, we talked about controlling that life-threatening bleeding. So any life-threatening bleeding you identify during your assessment. Control with direct pressure on all that. Large bore IVs, we want to consider those. And that doesn't mean, an adult population, 16s or 14s. A large bore for a pediatric patient may be a 20 or an 18, depending on their age range. So you're just going to have to judge that on your patient. If we can't get IV access, we can consider IO placement. When we get our IV access, we can draw some general laboratory values. Our laboratory values come in our secondary assessment, but if you're poking the kid for an IV, you might as well get some lab values. Our fluid boluses in pediatrics are 20 mLs per kilo. Usually we use normal saline. Sometimes surgery we'll use lactated ringers, but most of the time in our ED it's normal saline. Warmed or using a warming device. And when you're getting to that third fluid bolus, you probably need to consider using packed red cells because once you've given that third fluid bolus, you've now got 60 mLs per kilo in, which is the majority of their blood volume is now just water. So that's why we're considering packed red cells at that point. So in our circulation intervention, we want to intervene while they're still in this phase. As they get more tachycardic in their skin and they get cold and hypotensive, their prognosis is poorer than if we were to correct it when we're still in this area. So we want to identify these kids early and get them corrected. This is another slide that talks about, like I said, blood pressure. So we can see our cardiac output is maintained, and really we don't see a significant decline until around 50% of their blood volume being lost. This value, it says vascular resistance, which it is, but you can also think of your heart rate as the same thing. A child's heart rate will climb to try to maintain cardiac output before it falls off a cliff as well. And you can see blood pressure. Blood pressure actually will increase a little bit in that method as their heart rate goes up before you see that plummet off a cliff. So when we talk about fluid boluses, when we're resuscitating a kid, if this isn't your normal dehydration kid that needs a fluid bolus, this is a rapid infusion of fluid because they're hypovolemic. So at Children's we do what's called push-pull. If you put a kid, let's say you're giving, it's 25 kilos and you're giving 20 per kilo, so that's 500 mLs, how fast can you give it on your pump? How long will it take your pump to get in? Yeah, 30 minutes, because the fastest you can run it is a liter. And so this is where we do our push-pull. It's a stopcock management, really. You have your bag hooked up typically to blood tubing is what we use at Children's. And then a stopcock, your 60 ml syringe hooks to your patient. You draw up in the syringe. We usually recommend 50 mLs because it's easier to count by 50s than it is 60s. And then we push that in, and then we do it again until we get that full volume in. And this has been done for years, but it actually was, Mike Stoner is one of our ER physicians that actually kind of published data on it. So circulation, if she's 25 kilos, what's her circulating volume? I have a picture. Oh no, that's the answer. What was our circulating volume? And we remember back a few slides. So 80 times 250. Or 80 times 25, sorry, is 2,000 is what the answer is. So this little girl right here, I can't remember whose daughter this is. It's somebody at our hospital.
One of
But
our ED physicians.
yeah, she's got all of her blood is a 2 liter, okay? 2 liter of soda. And now she's lost 25% of her circulating volume just in this glass. So that's 25% of her circulating volume. This is when we're going to see her maybe start to be hypotensive when she's lost that much blood. Those are fun sounds. Must be their boiler. So those are our primary assessments. I didn't go through like disability because there's not a lot of interventions for disability during your primary assessment or exposure. We did talk about keeping them warm, so I didn't go through all of those. So then we get into our secondary assessment. This is our more in-depth assessment. This may never occur at your facility. You may have a severely injured child who gets a primary assessment, immediate interventions, and then gets sent off. This may never occur in your facility, and that's okay. It's not done until all the stabilization is done and the patient's life-threatening injuries have been done. But what comes in here is we can get our sample history. Then we go through a head-to-toe assessment. This is it comes from International Trauma Life Support. But DCAP, BTLS, TIC, and it just goes through, these are the things you're looking for head to toe, and it just gives you, I don't know, we all like those. And then also in our secondary assessment, we can look at labs. We talk about at Children's, we talk about x-rays, CTs, all of these labs. If they're going to delay the patient's care, the patient getting to a trauma facility, don't worry about them, okay? We don't want to delay care for any of this information. We want to get them to a trauma facility if we can. And you guys are a trauma facility, so you would be keeping these kids a little bit longer than some of our other community hospitals. I would say the most one that you would consider or not consider is CT or X-ray. Do I send the kid to CT if it's not going to change the outcome? Or if it's not going to change our management? It's probably not necessary. So now we're going to switch gears a little bit and talk about non-accidental trauma. So it's the #1 cause of mortality and morbidity in children less than 5 in the United States. Expertise, none of us are great at seeing trauma or non-accidental trauma because we don't see it. It's not our forte. So the more you see it, the more likely you are to identify it. And prevention of it and detection is difficult. 40% of children were seen at a hospital or a facility prior to so they've been seen and discharged. 40% of kids go home after having a non-accidental trauma because we didn't identify it. We can't look at them and say they're sick or not sick. Trauma we can, like a real traumatic injury. Oh, this kid looks like crap. Something's going on. We can't really do that here because we don't know. And we're not trained to be deception detectives. We aren't trained to interview parents and think, oh, they're lying or not lying. That's not our job. This is across the board. This isn't something unique just to your facilities or unique to Children's. So 31% of cases of abusive head trauma were missed on the first time. So 31% of those kids that come in that have head injuries are sent home. And of those 31%, 28% are readmitted or come back with more injuries a second time, and that's when we catch it. And then 40% of non-accidental traumas have something related to a poor outcome or some sort of medical complication because we missed it the first time. All right, so this one is a 26-day-old that is seen in the ED. I have more information. I'm sorry. I can't remember the exact case. There's a whole bunch of information on this kid. All right, so 26 days, that comes into your ED, comes in for kind of poor feeding. Does anybody know what this is right here? What? Not a burn. Close.
He came in with sick-like symptoms.
Yeah.
Kind of poor feeding,
Right.
snottiness, 26 days old.
Looks like a puncture wound.
Okay, yeah, you guys think it looks like. So our hospital, this kid was seen in our hospital. We thought this was a herpes lesion. So this kid was admitted to the floor for a rule-out sepsis, started in acyclovir, was treated as sepsis, and was discharged.
Classic age for viral type
Right.
presentations is 26 days old with those kind of symptoms. Had a low temperature, not high, but low, presented cool. And so he was worked up for sepsis, went to the floor, course of acyclovir, came back negative, and he was discharged home.
So this talks about it. Nothing was identified. He was discharged home. 2 weeks later, he comes back with some difficulty feeding. He's kind of lethargic, and he had some seizure activity. More psychosocial history. We found out, the sibling had a tibia fracture a couple months before, but no report was made. He was finally admitted to our hospital and had a full skeletal survey to look for non-accidental trauma.
So the psychosocial history, the reason I know this is this was my patient. So the psychosocial history was taken when this kid came back in, and this sibling was not identified to us when this baby presented the first time. So he wasn't presented. And the sibling was 5 months old when he had a tibia fracture. That should have been a huge red flag to this facility. This is a level 1 trauma center that we see all the time, so it's easy to be missed even in level 1 pediatric trauma centers. So at 5 months of age, this tibia fracture, we didn't investigate, was not reported to our child advocacy team, which is also known as our child abuse team. So it was never reported, so this was never caught. So then we did a skeletal survey on this kid, and it was normal. We're talking about our baby now, not the 5-month-old
Right.
sibling. The AST and ALT were also normal on the baby. These are really hard to see.
Yeah, these are hard to see in light, but there's some bruising here. Oh, some bruising here. They're really hard to see. Can you guys see it? I can see it, but I don't know that you can see it from the back. Here, there's some. This one I can't see either, but there's bruising behind the ear. That's what they're indicating there. And then we got a CT. I don't know that this was actually this kid, was it? Do you know?
Mhm.
Oh, you did it. And has a subdural hematoma. So, anything else to say, Larissa, before I go forward?
No, this baby survived, but was not normal post-survival.
Okay. So here what we're looking at is the frenulum. So this is the top of the gums, and this is, like you said, a puncture wound. So it's a frenulum tear. These can occur accidentally. A 26-day-old, it should not occur. They occur in kids that are ambulatory, fall, strike their lip on something.
Toothbrush in their mouth.
Right, climb out of a crib and hit their lip on the edge of the crib as they're climbing out. We can also cause them when we're putting in things. We could. I mean, I wouldn't think an endotracheal tube would be there or a nasal NG tube, but we could. So they can also be caused by abuse. So force feeding, whether that's a spoon or a bottle being rammed up into that top part of their mouth, whether they're hit, punched, or even forced oral sex, is the potential to cause that frenulum to tear. So any non-ambulatory child with a frenulum tear, we need to consider non-accidental trauma, so if you were to ever see that. So we do a thorough evaluation, physical evaluation. We do that psychosocial evaluation by social work. These kids are going to get, at Children's we have a child abuse team that actually evaluates this, so a multidisciplinary team that evaluates these children. They get skeletal surveys, head CTs, and like I said, that child abuse team. So this may be a kid that gets transferred to us for that further workup from you guys. It's just some other indicators of non-accidental trauma. This is pulling of the ear. You can see this bruising on the ear. So this kid's ear's been pulled. More bruising in the ear. It's uncommon to really have bruising in the ear. So more bruising. This is hair pulling. So this is a child that's actually been yanked by the hair, but we wouldn't ever notice that if we didn't do a thorough exam because the hair is down below the back of their neck. This one was an electrical cord, Larissa? I can't remember.
Handprint. Do you see the little finger? Yeah, that's
Not
a
really.
fingerprint.
That's a finger?
Yeah, finger. And then finger above that. Yeah, so that's pretty forceful spank on the bottom.
So a couple things to remember about bruising in pediatrics. Oftentimes, Dr. Scherzer, one of our physicians on part of our team, will tell you, we always go to court and fractures or bruises, oh, the kid has a bleeding disorder or the kid has osteogenesis imperfecta. Those are very unlikely. Most likely cause is non-accidental trauma. So bruises in infants are rare. They really shouldn't occur. An infant's non-ambulatory. There's no way really for them to get bruised. So just a simple bruise in an infant should be prompt you to do a further evaluation. I talked about that. And then as kids get older, it's more likely for those bony prominences to be bruised. So their legs, their knees, all those ambulatory childs that's learning to walk, oh, he fell and hit his knee, those things do occur. But to a soft tissue injury areas or other places like that are less likely to be from falls. They're probably more abusive related. And then I talked about the coagulopathy. So then we talk about trauma transfers. When do we get when, where, and who, and how? So when a patient needs to be optimally stabilized at your facility prior to transfer. That could include some sort of surgical intervention. You guys have surgeons on call. They need to be stabilized prior to transfer. Patient outcome is a direct link between the time. So the longer it takes for them to get definitive trauma care, the worse their outcome, and that's directly linked. So we need to get them to a trauma facility as soon as possible. Talked about life-threatening injuries. Don't delay that transfer for diagnostic tests that will not change the need for transport. So this is kind of up to your facility where your child's transfer, what they're comfortable with, and they choose the choose the transferring agency. You guys as a facility, that's up to you. And we can consult a physician at the receiving facility. So when you call our facility, you get to talk to the physician-to-physician report. So who gets transferred? Those patients that have signs of shock, significant physiological deterioration, progressive deterioration that's not getting better, and neurostatus is worsening. Those kids that are getting worse despite what you're doing probably need to be transferred. We talk about stable splenic lacs sometimes, or liver lacs are just observed, but if you can't manage them operatively, they shouldn't stay in your facility. So if you can't fix it and it all of a sudden starts bleeding, they shouldn't stay here. So that's going to be up to your surgeon that you guys use. And then high energy transfers, so those high impact cars and stuff like that, and we'll go more in depth. How? It's going to be, again, up to your facility. I worked for them, so I would say them, but I don't really mean that. On a pediatric trauma, whoever can get them to the facility quickest. We talked about that outcome being directly linked to their time from injury to care, definitive care, being a direct link. So who can ever get there quicker? Air, ground, that's stuff you're going to have to look at. Is there air available? Maybe ground, 2 hours already transferring to Columbus and it's going to take forever. Maybe air is a better choice at this point. Weather, obviously, is an indicator for when we can't use an aircraft. We also need to look at what the patient will need en route. These guys, which are just paramedics, I think, would not be able to handle some of the advanced medications. If you have, like, you're on an infusion for blood pressure, a pressor of some sort, they wouldn't be able to handle that. You need to do a mobile intensive care unit, as well as if they're on some sort of ventilator. Technically, in the state of Ohio, you have to be, if you're intubated less than 16, you have to be transferred by mobile ICU. So there has to be some sort of nurse on board. It's not in the scope of practice for a paramedic to transfer a patient on a vent if they're less than 16 years old. And blood would need to be a nurse as well. So this is just a little bit about our trauma program. We're accredited by the American College of Surgeons. We have to have some way to provide feedback to your facility on patients you transfer. So we send a referral letter. If there's performance issues that are really a concern, we'll give a phone call. We'll also follow up on seriously injured patients, and these are our coordinators. If you guys ever have any questions or want follow up on a patient that you transferred, you can call either of them. When we prepare a transfer patient, we need to do this ahead of time. It's better to have that ahead of time than to try to figure it out when you're there. These are our phone numbers if you're transferring to us. Like I said, that's that physician-to-physician report at that point. Establish it before you need it. The goal is to get them to a final disposition, so definitive care in less than 4 hours from the time of injury. This is kind of our internal goals. This is what we like to have happen. We talked about outcomes. Consider injuries and resources available. And then those high-risk patients, trauma alert criteria I'll discuss here in a minute. I talked about physician to physician. They talk about what happened. They give suggestions. They decide on a mode of transport. And then who's going to maintain control of that patient while they're on their way. Something different about us using Children's Transport Team, once the patient leaves your facility, the liability is now on Children's. When a patient actually goes by private service, your physician is responsible for that patient until they reach the receiving facility. So it's just a little bit of liability type things that happens. And then if anything changes before the patient leaves, call. Obviously your providers that are transferring them will call as well. We take that information to decide who we're going to activate. We also notify the PICU or 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 surgery if that's going to occur. Our level 1 trauma criteria, these are going to be different for each facility. Your guys' facilities probably are not the same, but these are our trauma alert criteria. Those are going to be hard to see on yours. Also new at Children's, we have a level 1 neuro trauma alert. So we use this on those patients. This one's a penetrating trauma to the head. That's a level 1 trauma neuro. This is a large shift. You can see a midline shift in there because of that blood. That's a neurotrauma. Any open intracranial or open cranial injury, and then a comatose patient that has unilateral pupils, so we're concerned. So if we don't get the CT, we can still do a level 1 neuro because we know that this is probably associated with herniation. So that's just something new we do at Children's. Then our neurosurgeons are at the bedside because our neurosurgeons aren't always in-house. Our neurosurgeons are at the bedside when the patient gets there. Our level 2 criteria, I'm not going to go over all those, but you can see them or I can get you more information. Remember the family in this aspect too. Make sure they know that the patient's being transferred and why they have to be transferred. Make sure you support that family, give them directions or anything they need. Your social workers can help with that. And then if the patient's not, the family can ride with us. I don't know what all your providers are, but Children's, we let family ride along. Not usually the abusive. If we're concerned of abuse, we usually don't let the parents ride, especially in the aircraft. So this is a patient that was actually at your facility. I'll do a quick case presentation, then we'll do some questions and answers. So this patient was actually seen at your facility. I think it was in 2014. So EMS calls your facility that they're transporting a 13-year-old who was an auto versus pedestrian, thrown about 30 to 50 feet, heavy windshield damage on the vehicle. He has obvious injuries to his head, jaw, arms. He has sonorous respirations or agonal, and they think he has a fractured jaw just visibly. His vitals are pulse are 80 and weak. Non-rebreather, GCS is 7 to 8, and they'll be here in 7 minutes. So anything you guys want to get ready, what would your facility do for this patient before they get here? Do you guys would this be a trauma alert prior to and everything? Okay. So make sure you get your patient, get everything in your room ready. This kid's a little bit older, but if it was a younger kid, you could warm up the room if you're concerned about that and just be ready for everything. So when we go through the A, B's, and C's, anything you're concerned about his airway right now? Okay. Yeah. So is it patent or is it not patent? Yeah, it's probably not patent. He's not breathing effectively. His rate would be low, I would say. His circulation is poor because he has a pulse, but it's weak. His GCS is low. We need to expose him when he gets here, and then we need to consider our family when we get here. So just to see the timeline of this is a great, pretty good timeline. Let me get the right words out. He was 9 o'clock was when the injury happened approximately. This is when EMS called to you guys. They'll be here in 7. Life flight was here to you guys by about 50 minutes after the accident. He got to Children's around 2 hours after the accident, so it's pretty quick. It's a good flow. So he was flown. The accident was about 35 miles per hour. He had multiple facial fractures. The right maxillary sinus, his right orbital was fractured kind of all over. His right mandible, his left mandible. His eye popped out basically, so it was protruded probably because of all these orbital fractures. And then he had lacerations, so these things were probably missed because we're focusing on this. I'm not saying they could be easily missed, these lacerations. Had a small pneumo at one point, nothing we did at Children's, pulmonary contusions. He had an adrenal injury, he was bleeding, so he had some adrenal suppression in our hospital. He had a left shift in his T8, and that was noticed actually in the trauma assessment. So that decap BTLS, it was assessed and found. His fibular fracture, tibia fracture, and then soft tissue of the knee. So he came to us. He was intubated here at your facility, transferred down to us. He eventually went to the OR to get that mandible fixed. Sorry, a little out of order there. So he was a level 1 trauma alert. He was concerned for some seizure activity in ED, so they gave some fosphenytoin. They noticed some unequal pupils, so he got some mannitol. And actually, he was initially hypertensive, and and then he was hypotensive. So I'm wondering if this hypertension was that indicator that maybe he had some brain swelling and was starting to herniate, and that's why they gave the mannitol. Because remember, our Cushing's triad, hypertension is associated with that. He had a severe traumatic brain injury, subdural hematoma. This was kind of through his hospital course. He did go to the OR and get a bolt, and that helped with his ICP pressures. And this improved his blood pressure as well. So I think once his swelling came down, his blood pressure improved, and these were weaned down. Just an X-ray. There's not. I just threw it in there. Nothing that exciting, but you can see he had a clear mandible fracture right there. Any questions on him before I go to any questions overall? Again, yeah, he did well. He had a pretty good outcome. He was non-weight bearing because of his knee injury, but cognitively still had some delay or some memory loss. He doesn't really remember the incident, but it sounded like reading through the chart he did pretty well post-op or after he was discharged. All right. Any questions on anything that I went over today, or any questions in general? Larissa, you got anything?
I just have a couple things to add quickly. At our hospital, any child who comes into the ED ages 5 and under, if they have an injury inside the home, regardless what the story is, regardless who witnessed it, regardless what they do for a living, they are automatically identified as a patient who needs to be evaluated by our child assessment team, our child advocacy, our child abuse team. And that's because so many patients get missed. The information might go to the child assessment team, they might read through the chart and sign off on it that way. It might come, they might interview the family and might be signed off on it that way. But every child 5 and under gets injured inside the home or on the home property gets a consult to our child advocacy team to hopefully help us not miss some of these patients. And then secondly, on who to refer to or who gets transferred, I think on that list we probably should include those patients you're suspecting non-accidental trauma. Even if they're not sick, they probably need to go to a pediatric facility to be evaluated, right? If you're concerned for non-accidental trauma, they need to be seen by the experts. Wherever you refer them to, I think that's probably a good person to add to that list of who gets transferred. Any other questions?
Alrighty. If you guys want to go ahead and fill out the eval for that one, and we'll pass it down. Make sure you do the one that's for trauma. We'll get Sheila set up.